These are my disclosures. So as you've heard in this panel, the treatment of femoral popliteal peripheral arterial disease depends on this presentation. Asymptomatic PAD, we do cardiovascular risk factor modification. For intermittent claudication, we do that, but we also do silastazole and supervised exercise therapy. In our practice, we intervene in claudicants only after they're either failed conservative management or have truly lifestyle-limiting symptoms. Things are different for chronic limb-threatening ischemia or CLI. We, of course, use medical therapy to optimize cardiovascular risk. We do limb-related soft tissue therapy in the foot to drain abscesses and do amputations of the toes to control sepsis. And, of course, revascularization is extremely important. We have two strategies available to us, endovascular surgery, open vascular surgery. It's wonderful. The more tools that we have to treat our patients, the better. Now, these strategies have their pros and cons. So open vascular surgery has durable outcomes, long follow-up periods are available, but it is invasive, and it's associated with blood loss, morbidity, mortality, and wound complications. Endovascular is minimally invasive. There's no need for general anesthesia, incisions, or hospitalizations. There is lower morbidity and mortality, but they're concerned about decreased durability, particularly in the more distal beds. It is expensive, and as opposed to most surgical situations, there's a lot of business interests that are at play. So I'll give you a couple of patient examples. So this was a 76-year-old man who had a history of claudication, who presented with worsening right toe pain and discoloration, the usual comorbidities. He had a remote history of lung cancer. He was a current smoker, normal femoral pulse, no distal pulses or signals, and he had a normal motor and sensory exam. Non-invasive studies suggested toe pressure of 0 and flat transtarsal waveforms. He did have good vein, and this is his angiogram performed from the contralateral groin. As you can see, a near flush occlusion of the SFA, a very large, juicy profunda that's collateralizing what appears to be an isolated segment popliteal artery. The proximal tibials are occluded, and as you can see, the runoff is via a peroneal and a slightly better posterior tibial artery as a target. So we chose an endovascular approach in this gentleman. We did put a sheath up and over to the right common femoral artery. We used the 014 system to actually cross the SFA, went relatively easily. We got down to the popliteal segment, and at that point it was obvious that we did not have the pushability, the torqueability necessary to cross the tibial occlusions. Our plan was to move a sheath into the popliteal artery. In doing that, we first wanted to angioplasty the SFA to allow for that to happen. We use a 3-millimeter balloon, and lo and behold, we got this problem. So now all of a sudden there's thrombus in the profunda and the common femoral artery. We treated that by putting a wire into the profunda, did a angiojet, did some ballooning to macerate the thrombus, used the penumbra, and in the end, we got this result. We chose not to continue to reopen the SFA, and in the end, the patient needed a surgical solution. And so the question is, was this the right strategy for this patient? Well, I don't know, and maybe not, since we had this complication. Another option would have been to proceed directly to a femoral posterior tibial bypass with great saphenous vein, which the patient had at the ankle. Patient number 2, 69-year-old man, bilateral, tissue loss, rest pain, typical comorbidities, current smoker, normal femoral, no distal pulses. You can see the picture of his foot. The toe pressure was 18. Again, good vein, access from the contralateral groin. Angiogram shows a SFA occlusion, very large collaterals, coming back to a very distal popliteal artery. The AT is out. There what appears to be is a moderate stenosis of the tibial trunk and runoff via the PT and peroneal. We used an 035 system here to successfully cross the lesion. We angioplastied with a 4-millimeter balloon, deployed 4 Ziller PTX stents. This was about 3 months ago. We decided to limit how we use our paclitaxel devices. So this is before we made this decision as a group. And then we did this, and then there was relatively poor flow into the tibials. And so we put a catheter lower down, and we saw that actually the tib peroneal stenosis was actually quite severe. We ended up deploying a drug-eluting coronary stent. And in the end, was this the right strategy? I have no idea. We stented the entire SFA, Popliteal, TP strong, full metal jacket, put a lot of stents in, a lot of money spent, paclitaxel used. I don't know about the durability. What I could have done is did a femoral posterior tibial bypass with GSV to a proximal posterior tibial artery. So we have a lot of revascularization strategy factors that we think about, patient-related clinical factors, patient-related socioeconomic factors, provider-related factors. People are doing whatever they're doing. There's really a drought of level 1 evidence. I'll give you what the evidence gap looks like. So if you compare CAD, cerebrovascular disease, and CLI, you can appreciate all the randomized trials that were done in CAD and CVD, and it's just a partial list. Only one trial done in the CLI. This is number of patients. Another way of looking at more than 100,000 patients treated in CAD to allow us to know exactly what to do in patients with CAD based on science. 452 patients in the basal trial. So we are running BEST CLI, and we're looking forward to both BEST CLI and basal 2 to give us guidance about treatment strategy. So in conclusion, choice of revascularization strategy in PD and CLI is based on multiple factors. Often this choice is not grounded in evidence-based medicine. Well-planned and orchestrated research is badly needed in this space. Dr. Ansel has made that point quite well. The BEST trial in basal 2 will answer some questions, not all questions, but it will provide groundwork for further level research and more questions to be asked and answered. Thank you.